My name is Dr. Edward Ngwenya, and I welcome you back to our plastic surgical podcasts. Today we continue with the topic of head and neck, wherein we will discuss quite a big topic, which is facial reanimation, or rather, let's say, the pathology that results from facial nerve dysfunction, if we may. So, this is a huge topic. So, as I always repeat, this is at a high level. We will get into minor technical details, but this does not seek to replace your learning. The assumption is that something is already there, the content is there, and this is just to remind you and augment your learning. Now, let's get into it without any further ado. Facial nerve. So I think we approach any topic, it's very important to know what the normal is so that we can be able to determine what the abnormal then is. And in surgery, you cannot fix that which you don't know what the normal is. Therefore, not only must you know the physiology therein, but also you must know the anatomy. And in order to understand the anatomy, it's very imperative that you have a firm grasp on the embryology because these are interconnected, and it will make your understanding so much easier. So, as per the facial nerve, if we look at it embryologically, I'll encourage you to just have a look at the books, therein. But what I can say certainly by the first trimester of prenatal life, we already have the path of the facial nerve already then planned. In fact, if you look at it at about you can say the fifth week of gestation, you can already identify the facial motor nucleus. And so this would then keep progressing throughout the sixth week. By the seventh week, the geniculate ganglions become a bit more defined. And so the course then continues intratemporally up until the facial nerve and its branches start to form in the extratemporal portion. Remember, the facial branches, or rather the facial or pharyngeal arches, are very important to know because we know that the structures that will be supplied will then be coming from the second brachial arch, as the facial nerve is the main nerve that supplies those structures. So it's important just to understand during development how everything then happens. But succinctly, one may say that by the time the child is born, the facial nerve anatomy generally approximates that of an adult, except for its location in the mastoid. And this you would find the facial nerve being more superficial therein, whereas in the adult, a bit deeper therein. So even though in the newborn we know that we more or less have the facial nerve anatomy, the nerve in itself is not fully developed until 4 years after birth. And there we'll be able to then get the full structure therein. So we know, I mean, that we are working here in with myelinated, nerves for fast action of muscle facial expression. We also have somatosensory and secretomotor functions that would then make up the other portion, which we call the nervous intermedius. So let's go in perhaps and quickly run through the anatomy of the facial nerve. Again, I cannot overemphasize that this is a topic you need to read. So this will just be touching, over what we generally can use as a description therein, or the way you can group it, and the way I like to group it is just to at least give the origin, the cause therein, and then would be able to understand pathology much easier if we know from whence it comes from, to where it is going. So that is very important. So just to give a brief description, we know with the facial nerve, there are two motor fibers and two sensory fibers. Now, the two motor fibers, the first coming, of course, from the second branchial arc, we'll call that the brachial motor. And that will generally supply the muscles of facial expression. Then we've got another motor component, which is the visceral motor component. Now, this is parasympathetic supply that will go to the lacrimal, the submandibular, the sublingual glands, and the nasal mucosa. So that then comprises the visceral motor component. Now, there are the two sensory fibers, which would be one for general sensory. So that would be touch, pain, temperature, specifically to the auricular concha, the external auditory meatus, and the tympanic membrane. But over and above general sensory, we also have our spatial sensory fibers, and this generally would be the chorda tympani, which would provide taste to the anterior 2/3 of the tongue. The cause is very important. It's imperative for you to be able to identify the three segments: the intracranial portion, the intratemporal portion, and the extratemporal portion. And once you can understand this and the cause, you will be there. It will be then easy for you to understand where lesions would then come from. Either they would be from the intratemporal, extratemporal, or they may be intracranial in origin. So we know that the primary, or rather the primary somatomotor cortex of the facial nerve is actually located where? In the precentral gyrus. Then we then have the origins coming in. Let's go through them with each fiber. Remember, we spoke about the two motor fibers and the two sensory. So the brachial motor, which we will call the facial nerve proper. So this would come from the facial nerve proper nucleus. And that's another name, is the facial nucleus. And this generally is located from the lower third pons. And so this generally would be the nerve to the temporal branch that we would know, would receive bilateral cortical inputs. So when we look at someone's head and we divide it, the nerve that would go to the temporal branches receive bilateral cortical inputs. But all other branches would then receive contralateral cortical inputs. Important to understand this, because if I show you a picture of a patient and then you see that, look, bilaterally the temporal regions are affected, then you would then know, that this receives a bilateral input. But then and you'll be able to locate where your lesion is. But if there's an issue on the contralateral side of the other branches, or on the one side of the branches, you would then know that the site where there's pathology is on the contralateral cortex. That's where there'll be a problem. So where does the visceral motor originate from? The origin would be the superior salivatory nucleus, and this also coming from the region of the lower third pons. The general sensory would come from the spinal nucleus of the trigeminal nerve, and this would be located at the medulla. And then the special sensory would come from the tractus, or rather we call it the nucleus tractus solitarius, which is also located at the medulla. So remember, we spoke about the brachial motor as the facial nerve proper. Now the others, which is the visceral sensory and special sensory motors, together are covered in one bundle, and those we call the nervous intermediates. So the nervous intermediates is the bundle that actually it's what they are called when they are covered in that bundle, these being the three fibers. The course you need to go and have a look at, because let's define the facial nerve proper so that we can understand. But it comes from intracranially, as I've mentioned, from the the facial nucleus. The fibers, you will see, they usually travel backwards first around the sixth nerve nucleus. And actually, as they go around the sixth nerve nucleus, they then will cause an elevation on the floor of the fourth ventricle. This we know as the facial colliculus. And then they would then travel backwards to exit at the midbrain, or rather exit the midbrain. Where would they exit? At the pontomedullary junction. And so once we've gotten that, then they enter, and we now have our intratemporal part, because they enter the internal auditory canal. And here, of course, traveling with the vestibulocochlear nerve until it reaches the anterior medial wall of the middle ear. The facial nerve proper would then travel in this internal auditory meatus, reach its end, which is the anterior medial wall of the middle ear, and then enter the facial canal. Now, what is this thing called the facial canal? We divide this into three segments. Now, the first segment being the labyrinthine segment, which is the narrowest segment that is there, and you will notice in patients with Bell's palsy, as we'll go in later, that's where if we want or we are pressed to do something, generally we know that's the narrowest point. We may want to do something there. And then the other parts, so the one is the labyrinthine segment, the other is the tympanic segment, and then the last being the mastoid segment. So let's have a look at it. So as it enters the facial canal, or rather another name being the Fallopian canal, it enters the labyrinthine segment. And this just after the internal auditory meatus, before the geniculate ganglion. So this would then go. Remember, I'm only talking about the facial nerve proper, because therein on this segment, the greater petrosal nerve will separate just before the geniculate. And so it would then travel, the middle cranial fossa, exits at the foramen lacerum to innervate the lacrimal and nasal glands. But that's not what we are following. We're following the facial nerve, which then travels in this segment, and then it will make a sharp bend posteriorly at the geniculate ganglion. A band, we call it a genu. So it will make a band, which we'll call the first genu, at the geniculate ganglion to enter the second bony segment. And then, upon reaching the posterior wall, it will then make another band, which is the second genu, and then enter the lateral semicircular canal. And there it will then start to travel as the mastoid segment, and would then give branches in the mastoid segment, actually the nerve to the stapedius, which helps to dampen loud noise would be there. The chorda tympani also exits there, I think, at the pterygotympanic fissure. And then there are other, of course, parasympathetic nerve to the submandibular and sublingual glands, which will then go therein. And that then defines the course of the temporal part. And the branches are important because that's the branch to the stapedius, and you would know then if something is affected there but other branches, facial expression are okay, then we know where the problem there lies. Now, the extratemporal part, which is important, it starts when the nerve, which is the mastoid, in the mastoid segment, exits the stylomastoid foramen. And so immediately as it exits this stylomastoid foramen, it would then give off three branches. The first branch being the post-auricular nerve, the motor and sensory, of course, from the general sensory. And then it would also give off the nerve to the posterior belly of the digastric, and also the nerve to the stylohyoid. These are the three branches then it gives off. And then it would then continue to travel, or rather this nerve trunk continues to travel about 1 centimeters inferior to the tragus to enter the parotid gland. And therein it will divide into the 5 terminal segments, which we know, and these are the 5 terminal segments that supply the muscles of facial expression. It's important to know where to locate the facial nerve around the tragus. There are many formulas, there are many points, but it's important for you to know, as it may be, one of the exam questions that generalists like to ask. Identify, how do you identify where the facial nerve then is? What are the landmarks? Very important. But we know it comes out and then it enters the parotid gland between the deep and the superficial lobe, and there it will divide into the 5 terminal branches. What are these 5 terminal branches? The first being the temporal, the second being the zygomatic, the buccal, the marginal mandibular, and then the cervical branch. Okay, so I think that actually I went into more detail than I anticipated, but that should give you a firm grasp over anatomy. What's also important to know is that there's a lot of arborization that then happens, this generally begins, in the substance of the parotid glands, because it generally lies in a fibrous plane that separates the deep and superficial lobes. But the two major, divisions, or rather, the pars anserinus will then divide. But then what I want you to just know is that there's a lot of arborization that would then happen in this area, and there are many different branching patterns, type 1 to type 6. I won't go into details, but we know that the most common being type 3, then followed by type I think type 2, and then it's type 3, I think, then type 4, and type 2 then would follow. But just have a look at those. What are the common branches and what are the common arborization and the patterns therein. But we know certainly the buccal and the maxilla, there would be a lot of arborization that's certainly found there. The location of where the nerves are important for you to know as well. The course of how the nerve travels. We know that the way to locate, you would use different points. We know for the superficial temporal, you can use something known as the Pittingui line, and you are able to then identify where it is, and that's a line that's drawn from 0.5 centimeters below the tragus and then 2 centimeters above the lateral eyebrow. We call that Pittinguy's line. There are other areas things that you need to know, specifically when you know about facial danger zones. The greater auricula is about 6.5 centimeters below the external auditory meatus. There's the marginal mandibular. Where do we find it? Usually mid-mandible. If you take the mid-mandible position, about 2 centimeters posterior to the oral commissure, that's where you then find it. There's the zygomatic and buccal branches, which generally are in, around the triangular area that you can mark. There's the supraorbital and supratrochlear in the superior orbital rim above the mute pupil. There's the infraorbital, which is about a centimeter below the infraorbital rim, mid-pupil position. There's the mental nerve, which is in the mid-mandible position, and this generally is below the second premolar. So these are just certain areas that you can then use to identify where the nerves are. But I think what you should know is how they innervate these muscles of facial expression. And generally, when you look at the facial musculature, it would be divided, in 4 planes. There's 4 layers. Layer 1, which generally would be high on top, that's the depressor anguli oris zygomaticus muscle. The orbicularis or oculi is one of the muscles. Then there are the second layers. Then there's the third layer, which is the orbicularis oris levator labii superioris. And then the 4th layer. But I think what's important perhaps is just to know the 4th layer is the mentalis, the levator anguli oris, and the buccinator. And the most important thing about this is that layer 4 muscles are innervated on their superior surface, while all other muscles receive innervation from their deep surfaces. And that perhaps might be important, especially when we go into raising flaps and doing facelifts, etc. So I think those are the important aspects. I'm not going to sit on anatomy any longer, but would then want us, to focus more on facial nerve paralysis. So with facial nerve paralysis, if someone asks what is the etiology therein, you would then, what you need to do is to divide it from congenital to acquired. And if it's congenital, we have things such as your hemifacial microsomia, your Mobius syndrome, lower lip, your Chiari malformation, syringobulbia, and other congenital anomalies, or genesis. It generally would give you the facial paralysis. But then on the acquired side, the way I would recommend that we divide them, as I initially did, was that we say it can be intracranial, intratemporal, or extratemporal. So what do we mean intracranial? What can affect? We can have aneurysms, vascular anomalies, CNS degenerative disorders. We can have tumors. CPA tumors are the most common intracranially, but any tumor therein, trauma to the brain can cause intracranial facial nerve paralysis. In the intratemporal region, what may be the causes? Bacterial, viral infections, so infective causes, cholesteatoma. What is cholesteatoma? Accumulation of, epithelial tissue within the intratemporal membrane. We've got the tumors in the middle ear or the mastoid. Most commonly, acoustic neuromas. You must think neurofibromatosis type 2. Generally, these patients would also have acoustic neuromas. Trauma to the temporal bone. So if you've got temporal bone fractures, any penetrating trauma, or any systemic conditions. What systemic conditions? Diabetes, HIV, even Bell's palsy, which perhaps we can quickly touch on, as it's one of those idiopathic facial paralysis we don't know much about, but this generally accounts for 85% of all cases of facial paralysis. And generally, we're not sure what the causes are. We know there is an association with pregnancy, but there are proposed a hypothesis, the main one coming out as the viral vascular insult to the facial nerve that causes edema of the nerve, mainly within the fallopian canal. Remember the facial canal, and this generally disrupts neural circulation, the microcirculation therein, and thereby it will impair conduction of neural impulses, or it may cause degeneration of the nerve. So that's what's thought to be the problem. But generally, it self resolves. And patients you would see within 6 months of paralysis, they will resolve. In fact, 71% of patients with total facial paralysis will resolve completely, and there may be just a small group which does not. And you would find the older a patient gets, the recovery will decrease with age. We think that the more damage to facial nerve results in more synkinesis and contractures actually that then happen. There are steroids that have been proposed, other studies where protocols would involve, giving about 60 milligrams per day for 5 days, and tapering it up until you're reaching 5 milligrams per day, by day 10. But we don't routinely recommend giving steroids, specifically in pediatric patients. But due to the hypothesis, remember the viral vascular insult, which causes edema in that small tight space, we then think perhaps it may assist. There are those that you may need to go in and operate surgically, but generally, you would keep it at a minimum, specifically to the thinnest component, which is the labyrinthine segment, where you can then decompress. But that's facial nerve, Bell's palsy there, as one of the intratemporal causes. And then we've got our extratemporal causes. What are those? Trauma. Any trauma, particularly penetrating trauma, or, remember we said it comes around the parotid. So if you've got pathology there, any malignant tumors therein, tumors anywhere else, the ramus of the mandible, the pterygoid, the skin, cancers that can go in, squamous cell carcinomas that may infiltrate that deep, or just primary tumors, schwannomas, primary tumors of the facial nerve can be another cause. And generally, I'm not going to go into the finer details, but you may get unilateral most of the time, but you can have bilateral facial nerve palsy, and this is very rare, usually, at most 2% of the population, but we know Lyme disease is one that actually had come out as one of the major causes, which is caused by a tick-borne disease. I forgot the bug. I think Spiritual Borrelia, but just double check on that. But HIV infection is something that has been raised, and Guillain-Barré, some syphilis, sarcoidosis, leukemia even, or trauma, some of the other causes therein that may cause this. But generally would have unilateral. In this brief, I'm going to stick mainly to the adults. We get certain condition in pediatrics, of course, which I'm going to stay away from, but most commonly congenital. Remember, we spoke about the, Mobius disease, which is just a primary developmental defect in the whole central nervous system, and in this congenital anomaly, most commonly you would get your facial nerve, which also may be associated with other nerve injury, but Generally would be, I think, the abducent, the sixth cranial nerve, which would be affected more commonly with that. And the main feature is just unilateral or bilateral loss of eye abduction. So mainly you'd see the lateral canthus, and then also it's, it may be complete or incomplete. And you look at these kids, you may have other features, specifically the lower lip that may be affected in these patients. And there's ways that you can look at that, but there are congenital unilateral lower lip palsies that you may then get from other causes other than that. But I'd just like us to, for this brief, to have a look at the adults rather than the pediatric population. I'm not going to speak about facial dyskinesis, of course, which can come from, hemifacial spasms, facial myochemias, essential blepharospasms in older women where this happens involuntarily, especially there's a disease or a syndrome called Make syndrome, where you've got blepharospasms, grimacing of mouth movements and then tongue protrusion. But we're not going to touch on this. All right, so how do we then assess a patient who comes in with a facial nerve injury? History is important. We want to know about the onset, the duration, the progression. How long has it been? We want to then also examine the patient, and we are looking for for signs. Is it unilateral? Is it bilateral? Do we have the both of the eye, the brows, if the forehead also affected? And generally what I like to do is divide my face into thirds. So you look at it as the upper thirds, the middle third, and then the lower third. The upper third, we're looking at the brow, we're looking at the eyelid, the laxity thereof. We look at the position of the forehead skin. We look at the Bell's phenomenon. It's very important because it is absent in 10% of just normal population, but you want to know if the patient's able to protect their eyes, So that is, when closing the eyes, the globe faces upwards. We want to do, our test, looking at our tear films, Shimmer's test, snap test. We want to check if the cornea does have sensation or if there's no sensation. Look at the light reflex, look at visual acuity, and basically you want to then look is the ptosis, and you want to then grade that. Remember the grade of ptosis for mild, moderate, severe, 2 to 3 mild, 3 to 5 moderate, and greater than 5 being the severe. You want to look at lid excursion, also quantifying it, I think from 5 to 15, greater than 15 very good excursion, less than 5 bad excursion, 9 to about 6 generally being moderate. So those are the values that we look at. You work with your ophthalmologist also just to assess the eye. And then we go down to the middle third, and we look at our, resting facial symmetry. You want to see, particularly paying attention to the nasolabial fold. Is the philtrum deviated? Is there, can you distinctly define the oral commissure? Is there tissue laxity? Is there maxillary hypoplasia, some of the congenital or traumatic causes? So you want to look at the vector, if it's negative, if it's positive, You want to also evaluate for nasal obstruction, and generally we do what we call the Cottle test, where if you raise the nasolabial side or the cheeks, generally the patient is able to breathe better, giving you a sign that if you fix this, it will then help that. And then would look down at the lower third, evaluating speech deficit. Is there drooling? How's the oral commissure? How's oral incompetence? Is there incompetence from this? And ask the patient just to smile, and you have a look at the lip, and if you have full dental display. And generally by that you can then grade the facial nerve dysfunction. There are many different grades. I like the the Sunnybrook scale, but there are others. There's the House Bregman scale, which looks at, it's a gross scale and it's most commonly used for reporting. But there are many other scales, the Barres-Fitch system, but Sunnybrook scale, House Bregman, choose one, and if you're happy with one, you can then use it. What else? There are a lot of diagnostic tests you can then use. I'm not gonna get into these, when you're wanting to test for etiology, viral tests, CT scans, MRI, you can use also topographic tests, as we've mentioned with the Shima's test. You're just trying to see, is lacrimation affected, stapedial reflex, to assess the function of the nerve to the stapedius muscle, the taste testing. Also, you can also use that, just to assess the chorda tympani, and these will give you an indication, and you'll be able to localize the intratemporal site or the extent of involvement therein. There are prognostic tests that you can use, from nerve excitability test, maximal stimulation test, electroneurographies, electromyographies, and generally those are tests that I use. EMG, not necessarily in measuring muscle activity, but generally, it may not become positive up until 14 to 21 days after the onset of paralysis. So these are just of the things to look at, because in theory the muscles are still alive and they can be re-innervated. And we'll discuss this further when we look at our reconstruction. And basically, when a patient comes to you need to have goals. You need to be able to decide when to act, the timing therein, and then you need to decide how to act. And these are dependent on many factors. How old is this patient? Is it an elderly patient? Is it a young patient? Do I need to reanimate, or can I use other measures that are there? But generally, you want to protect the eyes. You want to restore oral, nasal, ocular sphincter control, the normal appearance. Patient wants to smile with symmetry, have voluntary motion. So those are some of the things that you will then want to look at as your goals for surgical treatment. So I think let's go into our management of a patient who comes in requiring help for facial, with a facial nerve problem. So what are some of the things that we can look at? I think we can maybe break our approach from static procedures that we can do. So these are when we don't want to reanimate. We say, look, we're going to do static procedures for this patient, and then the other one, no, we want to now reanimate this patient. So the static procedures maybe we can go through, because all of this depends on, remember, the presentation of the patient. You can have a partial nerve palsy, and there you have basically two options. You then say, look, what I want to do, I can maybe augment the activity by introducing, some source of innovation. Maybe you can do a cross-facial nerve graft or nerve transfer, end-to-end, or end-to-side cooptation. Or you say, no, you what? I'm going to then, instead of boosting the other side, getting normal function, I'm going to then make the other side the same as the one that's affected. And this by reducing the function of the unaffected side. And you may use Botox to do this. That's just for partial, because we know it may regain function. But what do we want to look at? I'm going to divide these into, maybe let's talk about the acute management of a patient. Here's a patient who comes in with an acute full palsy. What are we going to do? Someone who's been stabbed on the one side of the face, they've got unilateral facial nerve palsy. So what we want to do before or within 72 hours, we want to make sure that we are going to explore. Remember, what are we going to explore? If there is the temporal is affected, the marginal mandibular, the cervical branches are affected, you want to explore and you want to explore quick. However, and these are injuries that are lateral to the canthus. However, when there are injuries that are medial to the lateral canthus, where the nerve is particularly very small, specifically affecting the zygomatic and buccal branch, those we don't have to go and explore. Why? Remember we spoke about aberration. So therein you may have aberration and regaining of the function. So those ones we don't have to intervene. But all others, within 72 hours, we want to go in and intervene, explore the nerve. And what are we going to find? If we find the nerve, this being the proximal and the distal stump, we are going to primarily anastomose, debride of course minimally, and then anastomose these end to end to each other, do an end-to-end repair. That's the first option in management strategy. The second, what are we then going to do? We may find that no, man, the distal and the proximal stump are too far from each other and I'm unable to bring them together. Generally, the book will tell you if a gap is more than 2 centimeters, then we are going to need to use a nerve graft. What grafts can we use? The greater auricular has been put there, advantageous because it's a local, it's with, operating field. But generally what I like is the sural nerve. It gives two-team approach, excellent size match to the facial nerve, and there's quite minimal donor site mobility. So you may harvest the sural nerve. But nonetheless, whatever nerve graft you use, you then graft that. You may use other things to add, like, an integral cover over that. There are other conjoint measures that you can use, alloplastic, things that you can use, and fine. There are options for nerve graft, options that you can use instead of nerve grafts to use other things. But generally, we are able to use nerve grafts, and there are sites that are available. Now I've got a patient who I cannot find the proximal stump. I only have a distal stump. And this is within, the early time of injury. It's not after 6 months. What can I then do? Then we say, no. You know what? If we have this, let's then go to the other side and do a contralateral facial nerve graft. So there we go. We look for the contralateral facial nerve, and then we will then graft it to that side if we are unable to identify the proximal stump. Now, here's a patient who comes, but the problem is that if this injury is now happening after 6 months, so they come in after 6 months of injury, but also before 2 years. Now, why do I mention this figure? Remember, after 6 months or before 2 years, during that interval, the end plates of the muscles we think are still alive. However, the muscle may slowly be losing its function, and we may not be able to keep them alive up until the whole neuralization process has happened for the synapse to then reach the end plates in this co-opted graft. So what do we then do? Then we can offer what we call babysitter procedures. Generally, this we can use, the mesenteric innervation. So we take the masseter. We can take 40% of the hypoglossal nerve as well. Because taking, as some used to take, a full hypoglossal nerve, there was significant mobility. Of course, as you can expect, the tongue would deviate. And so what we've seen that a mesenteric innervation or hypoglossal or dual innervation would work very well. So that we just then innervate that directly to the muscle just to keep the motor end plates firing. And this we can do with or without a free muscle transfer at the time. Of course, the free muscle transfer being our gold standard. So we've got this patient. We know that the muscles that are there, the end plates are dead. So this is an injury after 2 years. What are we going to do? Because the muscles are likely to be atrophied that are there. Then we bring another free muscle. We can use regional temporalis or the masseter, which is good for the lower lip. Temporalis, older patients, low anesthetic risk, it's local, you can use. But free muscle transfers, options are what? The gracilis it's a good option that's there. It is bulky, and it only gives you one directional pull. But the other option, but it's nice and easy to harvest. But the other option is the pectoralis minor, which is a bit more challenging, as a dissection to harvest. But the nice thing is that it gives you multi-directional pull and it makes for a more natural smile. So those are the options for reanimation. Primary anastomosis, or rather primary end-to-end repair. If a gap is more than 2 centimeters, you use a nerve graft. If now the injury is you cannot find the proximal stump, we go for the contralateral nerve, facial nerve graft. If then that the injury happens, after 6 months, but before 2 years, then we must add a babysitter approach. But if now this is after 2 years, there's no point in keeping these end plates. Those muscles are already atrophied. We then bring in muscle, whether it's regional, the temporalis or masseter, or it's a free flap, the gracilis or the pectoralis minor. And then you can just arm yourself to know what are the controversies. Now we have a situation where we're not going to go for innovation. This is an much older patient, high cardiac risk, and we think that anesthetic risk, and we think that no, you know what, for this patient, it's not worth going in and re-innovating. What are our other options that we can then give? Well, we can divide it into two. The patient comes in, we can give non-surgical or surgical procedures. What are the surgical procedures that we are going to give? This will go for a static reconstruction, or any patient coming after 2 years, contraindication to cause facial nerve grafts and free flap or free muscle transfer. Then we go for a static reconstruction. So what are the non-surgical? Before we go on to the surgicals, just how are we going to manage this patient? We're going to put topical lubricants, we give them natural during the day, that they keep putting Chloromax at night. They must put a night eye shield. Others have gone, as far as plugging the puncture, taping, patching, Botox, at the levator papillae superioris, and then others have then decided, no, we can then put external weights, just all to do what? To protect the eye. Surgical measures that we can then do, what are they? We can go for 3 gold weights, canthoplasty, or a torsography. Now, whenever we speak about that, let's start much higher. Perhaps let's start at the brow and go all the way down and bring, from up and bring down. So for the brow, what can we do? We can do a brow lift for the patient. Not such a nice procedure. I don't really like it. But look, you can do a brow lift using the palmaris longus or the fascia lata or a Gotex, and you can do this via a coronal, or others do it via endoscopic approaches. The other thing that you can use are just skin excision procedures, and that's what I generally prefer doing for these patients, skin excision procedures for the brow. Now, how do we address the upper eyelid? For excess skin, which we call dermatochalasis, we can do a blepharoplasty. For leg ophthalmos, what are we going to do? because you've got this patient with a ptotic eye, we are then going to do a lateral torsography. What is a lateral torsography? You know what it is. Applying sutures, and how far do you go? I like to use the medial, the lateral limbus as the mark of where you want your torsography to then end as a lateral torsography. Gold or platinum weights, but gold weights being the best in this area, are also things that are used. And so with gold weights, maybe what you can just know is the position where they can be put, either pretarsal or preseptal. But before you put the gold weights, remember they come in different sizes. You are going to need to measure and be able to show that the gold weight that you put is certainly going to serve the function that you want it to serve. So what do I mean by that? You can then use different measures, just have a look at those, but you can tape it on the outside first and see if it gives you the reach that you desire before you go and commit and put it in. Then we go for the lower eyelid. What do we then do for the lower eyelid? Because generally we'd have an atropion of the lower eyelid, and there we can use we can do a canthopexy. So you can pexy it, or you can do lid shortening, tarsal strip, and then you can do a canthoplasty that's there. As sometimes a canthopexy can give you a bulge, so you may want to move it. There are other procedures that we use, the Kuntz Szymanowski procedures. You then do your incision there, and then you can then add after you've done the lid shortening, you may also then add the canthopexy there. We're going down. For the nose, what do? We want to do a sling to the alar base. So we put a sling, fascia from the tragus to the alar base. But before we do that, we do the Cottle test. Remember, we spoke about it because we want to see if it will actually relieve the airway. And if certainly it does, then we can then put our sling. What do we do for our cheek and our upper lip? For the cheek and upper lip, we can do triple sling procedures where we put 2 slings on the upper lip and 1 on the commissure, and then we pull that all the way and attach it to the temporal fascia. And of course, there are other procedures. You can even go as far as a facelift, the retidectomy, to then assist in this. What are other things that we can do? Lower lip. The lower lip, we can go for a wedge excision, a full thickness wedge excision on the affected side. Or we can decide, look, let's just weaken the opposite side. How are we going to weaken it? We target the depressor labia inferioris. And there we can do a central myomectomy, a myectomy there, where you remove, a central 1 centimeters of the muscle. Or you do a myotomy, which is not necessarily long lasting, or others would also, just infiltrate Botox, give botulinum toxic, which we know it's also non-lasting in that area. But I'm not going to go into the controversies, but for a better smile, you choose. The timing, we know during the first year, is a good timing. During the first year, the rate of recovery after the injury has generally, it's been shown to predict long-term recovery. So you want to do it then. What test to use? The grading scale. There's an article on controversies. Have a look at it by Kim. In the surgical clinics in 2016, and he looks at grading scales and generally says the HB or the Sunnybrook scale are the most commonly used. Smile re-innervation, he says, look, your cross-facial Nervecraft are generally good. your mesenteric nerves, hypoglossal, and then he concludes, you know what, if you combine the two, it actually works much better. And babysitter procedures, should you do dual, as we say, we use dual procedures for those. Regional muscle versus free muscle, and that will be determined by the patient's age. But we know the gold standard is a free flap, but free nipple, free muscle transfer, but this is best determined by the patient's age. But when you use, as per best practice, the free muscle transfer, gracilis is actually the current criterion, for a standard smile, or dynamic smile in reanimation. So I think, yeah, from the management, I think from what I've given you, you should be able to then, manage a patient who then comes in. I think we've touched on basically everything. Perhaps I can say the non-surgical adjuncts that you can just add at the end. We need meticulous eye care. We want physiotherapy. And early strategies for flaccid facial paralysis. They really center around on anatomical facial muscle education. And these will include, soft tissue massage, passive stretching, mirror exercises to promote the facial muscle movement. But once the motor movements are recognized, therapy strategies, they can assist, and they would generally evolve around, the triggering specific facial muscles and be rather focused there. I think we've covered our facial nerve. We've been able to determine the embryology, the anatomy, what are the etiologies thereof, and how do we manage someone who comes in requiring assistance on an acute level, and on a more chronic level, on facial reanimation and on static procedures, non-surgical and the surgical, and how to then manage the patient thereafter. I thank you for your attention, and we look forward to the next presentation. You take care. Bye-bye.